Good day to everyone, and welcome to today's webinar entitled How Hospitals Can Optimize the Value of Digital Technologies Using a Smart Connected Hospital Framework. My name is Mark Haglund, and I'm Editor-in-Chief at Healthcare Innovation. Today's program is sponsored by Vocera. Thank you very much to our friends at Vocera and to you in our audience for giving us your time and attention today. Before we get started, I have a few housekeeping details to share with you. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag #HILiveWebinar. At this time, it's my honor to introduce our speaker for today's program. Our industry expert and guest speaker today is Dr. Ben Kanter, the Chief Medical Information Officer at Vocera, now a part of Stryker. As CMIO, Dr. Kanter works closely with engineers, clinicians, IT leaders, and others to co-design the next generation of real-time communication and collaboration solutions for hospitals and health systems around the globe. Prior to this role, Dr. Kanter worked as an industry consultant with several healthcare IT companies and was a CMIO at Palomar Health in San Diego, where he spent 7 years on the executive management team. Dr. Kanter earned his medical degree and completed his internal medicine training at Northwestern University and completed postdoctoral studies in both pulmonary disease and critical care medicine at UC San Diego Medical Center. Dr. Kanter is board certified in internal medicine, pulmonary disease, and medical informatics. It's my pleasure to welcome you. Welcome, Dr. Kanter.
Mark, I appreciate the introduction. Thank you very much. And to those of you who are joining us today, thank you for your time. My presentation probably won't last more than about 20 minutes. Really, I do that because it's hard for me to sit through a webinar for more than 20 minutes, and I know that everybody's busy. I'll have plenty of time for questions and answers at the end. So with that, I'm going to jump into the body of the talk. So good morning and good afternoon, depending on where you happen to be. And again, thank you for joining me. Since I can't be with you in person, I can't ask for a show of hands, but please bear with me as I'd like to start with a quick yes/no polling question. Are you familiar with the concept of the smart hospital or a similar term, real-time health system? Yes or no? And if you wouldn't mind, please letting us know, that would be great. So either we have there we go. Now things are starting to roll in. I was getting worried there. Give it 5 more seconds. And then if we could push those results to the audience, that would be terrific. Thank you. So it looks like we're sort of around 60%, 70% saying yes, they're familiar with the topic, which is great. That helps me as I'm moving through this. So I appreciate that. Thank you very much. All right, to level set then, for our purposes, hospitals, really any enterprise, are smarter when they're able to derive insight and value from all of their connected systems, right? This holds not just for hospitals, but for other organizations. And to be honest, this definition is sort of like mom and apple pie. What's missing from this particular description, in my opinion, is speed. The speed with which hospitals make use of data to transform care is really critical. That's where the ROI is. That's where your value is. This is specifically addressed in a Gartner consulting paper that they published in 2017. They describe something they call a real-time health system in my opinion, for me, that term is materially the same as what constitutes a smart hospital. And the defining characteristic of which, in Gartner's view, is the use of information and communications technologies to reduce the time it takes to access relevant historical data or to churn new data into information, analyze it, communicate it, and apply it in practice. Again, shortening the time to act, that's the key. Now, this is a really important topic, right? For the last 20 to 30 years, hospitals have been investing significantly in digital technologies, gradually moving from the paper environment to a more digital environment. And the question on the table today is, how can we improve the value we're getting from these various digital technologies that have been implemented over the decades? This obviously isn't digital. I began my personal professional journey as a medical student at Northwestern back in 1978. So I've had the opportunity to live firsthand the transition from an all paper, if you will, analog practice environment to one in which digital has become king. And in order to appreciate where we are and why we are where we are, it's important to understand where we came from. So although I don't have a picture of the med-surg wards of the 70s or 80s, I do have this image of the ICU where I worked, and I think this is probably circa 2000, and it's representative of how we used to work prior to the conversion to a more fully digital environment or the fully paperless electronic medical record. For those of you who are listening, who are old enough, you'll remember when all of the results came back on narrow lab slips that were delivered to the ward clerk's desk. These had to be sorted and pasted into the patient's chart, one section for chemistries, another for hematology, etc. And it fell to the medical student to get a hold of this information either off of the clerk's stack or from the chart and compile it with prior labs on a paper spreadsheet that was part of the rounding team's work. So reflect on the time involved, the results generated in the lab, a paper slip is produced. The lab waits until all the unit tests are resulted and the paper slips are aggregated, packaged, and carried or tubed up to the ward. Once on the floor, results weren't put into the patient's record as they arrived, right? Rather, the slips were organized by room number and eventually pasted into the chart when the ward clerk had time. And just as today, stat labs were called to the floor and the physician would be contacted via pagers in most cases. By the 1990s, lab results were commonly computerized and available for review online. Those systems weren't organized in a patient-centric way. They were encounter-based, right? They were reflecting the original focus of computerization, which was to improve billing efficiency. In other words, I couldn't go to a patient's chart and see in an aggregated fashion all of the information in one place. Each patient's encounter was stored separately. And if you're looking for a specific lab result and you didn't know which encounter was the right one, well, I'd have to go and open each one by one until I found the information I wanted. And again, in order to get an aggregated view or trend something over time, you'd have to log in and out of every disparate encounter, copying information like lab results over to a paper spreadsheet. And I'll point out something that remains true today. If the result wasn't critical, it simply went into the record, paper in the past, digital now, and it simply sits there. Information sits there until someone goes looking for it. I'm hearing background noise. I'm not sure from a technical standpoint what's happening, but I'm hearing what sounds like machines in the background. All right, so this process was obviously inefficient, which meant that time was being wasted. And that was just for labs. The actual records were locked away. So if I wanted to see notes or other information, I'd have to wait until someone could locate the correct file or stack of files and deliver them to wherever I happen to be. And that could take a dangerously long period of time from a patient standpoint. So what were the original goals of our transformational journey to an all digital or paperless environment? Fast forward to 2004, President George W. Bush's State of the Union address, when he proclaimed that by computerizing health records, the U.S. could avoid medical mistakes, reduce costs, and improve overall care. And in a bit more detail, recall that the president set an ambitious 10-year goal that by the end of that period, most Americans would be cared for by using electronic health records. The stated primary goal was to ensure information was available when and where it was needed. The White House commented that these innovations in electronic health records, in concert with the ability to securely exchange information, would, for the fourth bulleted paragraph here where I've highlighted it in red, improve healthcare quality, prevent medical errors, reduce costs, improve administrative efficiency, reduce paperwork, and increase access to affordable care. In retrospect, we now know that we've substituted new types of medical errors for those prevented by EHR adoption. Costs of implementation and administrative support for EHRs has skyrocketed. The electronic health record cost probably is only exceeded by the cost of opening a new hospital building from a capital standpoint. Reduced paperwork has been replaced by increased computer work, etc. So what this emphasizes to me is to that first point, improving healthcare quality. The pressing need is to improve quality by making the best possible use of these digital systems we've all implemented. Now, as a clinician, and I'm pulmonary critical care, as was mentioned, the quality of the care that's delivered is paramount. Everyone's aware of the Hippocratic Oath. Hippocrates authored the statement we now simplify to first do no harm. But the first of his aphorisms is equally famous, the Ars Longa Vita Brevis. This emphasizes that it's a lifelong journey to learn the art of medicine, but our lifetime is short, and the opportunity or window in time in which we can successfully treat a patient is fleeting. Finally, making judgments in the care of patients is difficult. And just as justice delayed is justice denied, so a medical judgment delayed can lead to disability or death. Judgment requires situational awareness. And when communication of information is delayed, then the situation you're addressing may actually no longer be the case, right? Plus, many medical conditions are very time dependent for the best outcomes. You're probably all aware of the importance of getting a blocked coronary artery opened as soon as possible when a patient's having a heart attack, AKA the American Heart Association's mantra, that time is muscle. And time sensitivity holds for strokes and sepsis and many other conditions. So one could argue that the two of the major drivers for our digital journey are, first, an improved ability to share existing information, and second, shortening the time it takes to recognize, report, and respond to new events, whether those are clinical or administrative. All right, enough about how we got to where we are. The problem now is no longer how do we implement digital technologies. It's the struggle to make sense of all of the data that's being generated by the various systems, and then acting on the new information when it's actionable as quickly and appropriately as possible. In today's environment, digital infrastructure is pervasive, but for the most part, each system exists within its own silo. Each of these systems can generate warnings or alerts, which are really just a type of clinical decision support messaging. And these messages can be sent to one or a number of people depending on the need. But each alarm, each system, whether it's generated from the electronic health record or from your lab information system or equipment in the patient's room like an out-of-bed alarm, each of these react and respond in isolation as if they're the only system capable of sending alarms in the entire hospital. And the end result, the first responder, in the vast majority of these situations, is the nurse. And the unfortunate nurse can get just flooded by alarms. And although each alarm may be important, each is also an interruption. And interruptions lead to errors and interruption overload. We used to talk about alarm fatigue, right, as a cause of patient errors. But the reality is that it's actually interruption fatigue. And that's assuming that all of these warnings or alarms or messages are actually meaningful, actionable and are being routed to the right person. So the end result is chaos, cognitive overload, job dissatisfaction, and burnout. And I refer to it as a perfect storm of good intention. If I were to anthropomorphize a digital system, I'd say that each system is really trying to send a message, be it an alarm or a warning, to get the attention of someone who can evaluate and fix whatever the problem is. But who's protecting the nurse, passing medications from a low priority interruption, which could result in a medication error? Or a nurse at a code blue whose focus shouldn't be distracted? Or a message that instead of going to the nurse could have been handled by someone else, or simply information sitting in the medical record that should be acted on, but nobody's gone in to extract it. Or in a bit more complexity here, think about the following. Does every patient who's getting out of bed deserve the same out-of-bed alarm going to the same person in the same role with the same priority? Shouldn't a patient with a normal body weight who's ambulatory have a different alarm and routing than a morbidly obese patient who's a documented high fall risk? They're very different scenarios, yet most hospitals treat the out-of-bed alarm in the exact same fashion. Smart hospitals wouldn't do that. Now time for another digital hand raise. The questionnaire here. So the topics related to cognitive burden, information overload, and interruption fatigue are really high-level major discussion points among clinical leaders across the country. The question here is, do you think they're actually top of mind at your organization? And remember, all responses are anonymous. So if you wouldn't mind responding yes or no, and again, your responses are anonymous. Give you another 10 seconds here. So of these 18 people that have thus responded, 2/3 say yes, 1/3 say no. I have a follow-up question. And this question and follow-up is for those of you that answered yes. So if we could push the next question out, and that is, if these are top of mind at your institution, is your organization taking steps to reduce these contributing sources to burnout? Is this being talked about, or are there actions in place? Oh, this is great. So the early returns are the vast majority where this is top of mind are actually taking action, which is really wonderful to see. Give you 5 more seconds here. Okay, of those that responded, 3/4 say yes, the organization is taking steps, and a small minority are saying no. So that's good to know. All right, we've devised a smart, connected hospital framework to help leaders visualize how to make the most of their investments in digital infrastructure with the goal of improving care team experience, patient safety, and other outcomes. This framework, from the bottom up, shows how different types of interoperability work together in the clinical ecosystem, starting with interconnected data sources and feeding up into the end user experience. Our framework consists of 4 levels: the foundational input layer, second layer representing aggregation and intelligent data processing, a third layer being experiential, and the fourth is analytics. The input layer features data interoperability between the disparate IT systems, such as the electronic health record, physiological monitoring equipment, smart beds, and other medical devices. Data interoperability creates the foundation for connectedness. The aggregation and intelligent processing layer breaks down silos and makes data from multiple different sources available for processing into information. This is the necessary step to determine if the data requires immediate attention. Data is aggregated and processed using rules or algorithms, and based upon the resulting information is teed up for the experience layer. The experience layer is where the rubber hits the road. It reflects information being communicated to the appropriate staff members on their device of choice, supporting their various workflows. Another way to think about this is that this layer reflects the activities needed to actually support the making use of information in practice. Finally, continuous process improvement, a cornerstone of the development of smart hospitals, is something you can't do process improvement in the absence of data. Analytics are crucial to measure your clinical and economic outcomes and gauge whether or not appropriate value is being received from digital technologies. From an architectural standpoint, a modern communication and collaboration system is the technology that underpins this entire model and makes the system hum. How so? Why is that? With the goal of shortening the time it takes to address clinical and operational issues, of rapidly recognizing when something has changed, reporting that change, communicating it, and responding to that change. Recognize, report, respond. Here's how we tackle it within the Vocera platform. On the left side, you see various hospital systems which provide data input into our platform. These aren't meant to be exhausted. We have more than 150 different system interfaces. But the point is that these are generally siloed sources of data, siloed streams of data that can flow into the platform. The data flows into our aggregation and processing layer in the middle, which is represented by the circle, one component of which is what we call MDAN. It's our 510 cleared secondary alarm notifications software. So part of the middleware platform is the alarm notification piece. If something does need to be communicated, who should it be communicated to? Well, in order to appropriately report new information, the system needs to have a deep understanding of team member presence. What are the care team assignments? Who's working? Who isn't? If someone's working, is he or she available? And who's in what role at this moment? If we have that information in hand, then communications can take place in a way that guarantees delivery. So the system uses rules and logic. Data from these disparate systems can all be intermixed and processed and churned into information, which can then be messaged out. And the speed with which this can happen, because you're integrating your communication systems directly with your information processing systems, is really what helps make the system more agile, makes your hospital more resilient, and makes your hospital smarter. Now, this information is output. That's on the right-hand side here. And the output layer is where information is being sent to the nurse or physician or to any combination of team members or devices. And I would be remiss if I didn't mention that communication systems should be agnostic as to what mix of devices you choose to employ in your environment. Each role in an organization has unique workflows and unique communication needs. They have the best tool for their job, in this case, best communication tool. The best communication tool for a private practice physician may not meet the needs of a nurse or lab administrator or transport tech, etc. So whether they're enterprise provision smartphones, a physician using a personal phone in a bring your own device environment, or supporting staff when they need to communicate in a hands-free fashion or safely communicate when wearing PPE. Your collaboration platform should be able to support all of these. Now, I showed this slide at the beginning, and I hope it makes complete sense now. It isn't being digital that makes an institution smart. It's what you do with digital that makes you smart. And as we look back on our health information technology journey over the past 30 years or so, Most hospitals have invested in the architecture, but how many can truly say they're able to leverage the information being generated and get it in the hands of those who are responsible and accountable for acting on it in near real time? By directly connecting communication and collaboration platforms with your various digital systems and information processing infrastructure, the institution becomes more resilient, smarter, more nimble, and the work required by care team members is reduced while patient outcomes are improved. For more on this topic, I invite you to read the white paper. And the white paper, if you take a look on your console at the bottom left, you should see something that's something like presentation resources. Under the resource tab, you should see a link to this paper, which you can download, or you can reach out to me directly. And of course, it's available from our corporate website. So my contact information is on here. I'd like to thank all of you again for joining me. And we've got time for questions. So Mark, if you could rejoin us, and that would be great. Thank you.
Thank you so much, Dr. Kanter. I am here. I hope everyone can see me. That was terrific. We have a couple of audience questions, but I have a general question. If you were to just guess, totally overall sense, what percentage of hospitals and health systems would you say would you describe as advanced along this journey that you've described in your presentation? Is it 10%? Is it 20? And you get to define what advanced is, the whole thing.
I was going to ask you if you had an objective measure for advanced. Okay, so I would, I think it's a bell-shaped curve. I think that advanced, maybe 10%, maybe. But I think most hospitals have recognized that they put these systems in, and they're all struggling now to do a better job of doing real-time use of this information. And I'll just reflect on the changes I've seen in a hospital-based CMIO role. When I was first a CMIO, right, which was quite a while ago, the role was, the go-between between information technology systems on one side and the EHR vendor on the other, and you were there to sort of, protect the clinician during the implementation. I think that the role now for a CMIO is not so much how do you implement, it's how do you leverage the data that you're generating.
Yes.
And there is just an avalanche of data. It's going to increase as we start to see 5G. I mean, real 5G, not the fake 5G that's being advertised. I think the amount of medical data from wearable sensors inside the hospital, outside the hospital, and other sources are going to continue to overwhelm our caregivers. And so this is a problem that, as we might say, hey, it's nasty and confused and chaotic inside the hospital today. It may not get better, and it won't get better unless we all recognize that our first responders, our nurses and physicians, need to be protected. So it's tough for me as working for a communication company to say communications are great, but we got to be real careful.
Yeah, absolutely, doctor. And let me ask you one follow-up to what I just asked. There's a lot of talk now about the CMIO 2.0, well, every kind of O 2.0, right? And generally speaking, I'm referencing what you said earlier. Yes, at the very beginning, the CMIO role was primarily related to implementation, right? We're going to implement in the HR. Let's corral the stock, Dr. Smith, who's, a tech head, and he or she is someone who can kind of stand between the different groups and say, kind of be a little bit of a referee, right? And say, well, this is good, this isn't good, I side with the doctors here, I don't there, whatever. The level of leadership that's going to be required going forward now is so immense because we're trying to really execute on clinical transformation, right? For improved outcomes, curbing costs, moving into value-based care delivery and payment. And just your thought real briefly on, are CMIOs up to this? Everything that you've explained and shared with us in your great presentation here speaks to a lot of challenges, a lot of leadership challenges.
It's a different environment today. When I was leaving my hospital organization, I sat down with our chief information officer, who I worked very closely with, and I explained that the next person they should hire into my role, assuming they did, should not have my background, should have a much more explicitly trained background in, for example, database analytics and things like that. Because if we don't make use of this data, and not just make use of it 2 weeks after it comes in, but make use of it in near real time, then we're really kind of spinning our wheels. The smartest hospitals, most resilient hospitals, look at their data, determine which information is actually meaningful and actionable, and try to act on that as quickly as possible. And it is a very different environment today.
Absolutely. Absolutely. I agree. So we have a question from the audience, Doctor. Can you explain just a little bit more about why integration of a communication system with analytics is so important?
Yeah, so for the same reason, that's a good question. For the same reason that when lab data comes back, if it sits in the electronic health record, it's really not benefiting anybody. So the same with data and information. When you've broken down your data silos and you've generated information, let's say it's a sepsis algorithm that's either detecting that somebody's deteriorating or is predicting that they're high level of deteriorating in the future. If you can't get that information to those that are accountable as swiftly as possible, you're starting to lose the battle. And so for things like unanticipated transfers to the ICU, right? Those would be a normal rapid response call. There's literature that shows that literally for every 15 minutes that there's a delay, you can see changes in outcome, worsening outcome. Things are very, very time dependent. And so it's time. It's all about executing as quickly as possible. And then from a hospital standpoint, administratively, the faster you can get a room clean, the more people you can get into your system, the more people you can help. Throughput is absolutely key. And again, it's time dependent.
Terrific. Thank you, Doctor. I have two final follow-up questions for you, if you don't mind. First, how do you see this landscape evolving forward, everything you've described just now, in the next few years? If we were to have this conversation, say, 3 years from today, would we be talking in different terms about different things compared to now?
Yeah, so I think consolidation is the first thing that comes to my mind when you ask that question. So I'll talk about, for example, nurse call. Nurse call from a patient standpoint is something they have direct control over. It's something that, again, is very time dependent from a patient standpoint. I think that nurse call in the future actually becomes part of your communication and collaboration platform. So you'll see consolidation there. As telecom continues to progress, as we move to more and more smartphones in the hospital, the idea that every single alarm, every single thing that has value should be sent directly to the nurse is going to get questioned. I think that alarm committees inside hospitals need to basically exercise their power and need to be more involved in these sorts of programs. Because before nurses were using smartphones, before we could route any of these things to nursing staff, studies were showing that nurses were being interrupted, let's say 12 to 18 times an hour. Well, there's only a finite bandwidth. We may have all of this great information that's pouring through the system, but if we keep sending it to the nurse, he or she is never going to have any chance to get any real work done with the patient. So I think we're going to see emergence of telenursing inside the hospital, some kind of nursing resources that are doing a triage in a different way, taking some of this information overload off the shoulders of our nursing staff. And of course, we're all very aware of the nursing staff shortages. My daughter is a nurse. My wife is a nurse. It's a tough place to be right now. And I think we're going to see more and more systems that are going to help protect our caregivers and intelligently filter this information.
Yeah, I just have to say I agree 1,000%, Dr. Kanter. Or as a good friend of mine would say, I agree violently, because we simply must unburden our nurses to some extent, just the extent we can. They were already the most interrupted people, and you cited the statistic. Many of them are feeling extremely burned out now. We just have to help them. We cannot have nursing staffs where, every third person is saying, I'll quit tomorrow. It's bad for all of us, obviously.
The burnout problem is an issue. Again, it's a perfect storm of good intention. These messages aren't being sent to the nurse with bad intent. They're all meaningful. The problem is the human mind, somebody doing work, can only absorb so much in a short period of time. So hopefully we'll also see systems change so that, let's say I'm an orthopedic surgeon, the information that will come routed to me will be customized and delivered in a way that meets my needs, as opposed to a cardiologist or an obstetrician, or if I'm a floor nurse, differently than somebody who's an OR nurse. Right? I think as these systems get more sophisticated, our ability to move away from, there'll always be enterprise rules for which information gets pushed out automatically. A critical lab, potassium level of 2 is going to get pushed out automatically. But as let's say, again, as an orthopedic surgeon, the hospital may say, hey, a hemoglobin of 6 needs to be pushed out. I may want to be notified for hemoglobins of 7 or hemoglobins of 7.5 for my patients. I need to be able to easily construct those notifications for me so that the system is working for me. I'm not working for the system.
And again, I'll just say, I think clinical informaticists, both physician and nurse informaticists, are going to be deeply involved in the optimization work around those processes going forward.
I hope so. I must say that in my experience, alarm management committees, sort of in most places are almost an afterthought to some of the Joint Commission pushes over the past 5 to 10 years. I think they're incredibly important. They're going to become increasingly important, because if you don't have an objective way to measure what's interrupting your staff today, you have no way to protect them in the future, or to say, if I'm going to turn on a system, let's say it is a new alarm system for sepsis, how many alarms per patient per day is that generating? What is that going to do to the average nurse on the floor's workload? How many of those, what's the positive predictive value? You need to have an informaticist or somebody who deeply understands workflow and interruptions to be involved with the design of those systems.
Absolutely. And my last follow-up, I know this is an unfair question, but hyper elevator advice, right? Everything you said implies some advice, but if you have 45 seconds as you're going from floor 1 to 6 with someone, what would you tell them about all this? What should they most prioritize in the coming months?
You're talking about what they should prioritize from a hospital investment or hospital planning standpoint?
Yeah.
Yeah. All right. So I would say that no one part of the hospital, informatics or administrative or analytics, no one team can solve these issues. It takes your clinicians sitting down with your informaticists, with your informatics people, with your analytics people. They need to be at one table. And I would say, invest in solutions that help you understand what's happening on your floors in real time. Which floors are getting overloaded, which floors aren't. We're working on systems to look at, which patients, which staff members may be getting overloaded from alarms and alerts. I would say take a fresh look. Don't just put in a smartphone because everybody's putting in smartphones and your electronic health record vendor says all the nurses should have smartphones. Fine, I like smartphones. I'm not anti-smartphone. But as you start to turn on the functionality, be very careful. Do it with somebody from your nursing staff who the nurses can go to and say, these alarms are set up incorrectly for us, and try and do it in an objective, evidence-based way.
Fabulous advice. Yeah, no, I really appreciate it. And we may have gone from floor 1 to 10, but that was perfect, Dr. Kanter. So I want to thank you, Dr. Kanter, for a terrific webinar today, for your presentation. And I'd like to thank Vocera for sponsorship of today's program. So unfortunately, that's all the time we have for today. I want to thank everyone in our audience for joining us. We hope you'll join us in the future for another healthcare innovation webinar. This concludes today's presentation. Thank you all and have a great day.
Thank you very much.